From my point of view, I prefer the posterior leg axis to get a subjective impression of the patient walking, whereas when I go to quantification, I prefer the anterior camera when it comes to the coronal plane, because it's more neutral against rotation. So that's where you view. I prefer the posterior leg axis to get a subjective impression of the patient walking, whereas when I go to quantification, I prefer the anterior camera when it comes to the coronal plane, because it's more neutral against rotation. So that's where you go for the interior then. But as for the subjective impression, this could be a good first starting point where we may see a perfect shape of the gastrocs. So really neat swing face, it's just passing by smoothly, even if, well, the lower limb is rather well equipped in terms of soft tissue structure. So in her case, I would actually say this is some kind of muscle tissue that needs to be located underneath. And if you just want to have an impression of the gluteal fold, how it's moving and how it's behaving, that could already give you a good indication of a severe pelvic rotation. So whenever I'm moving the leg backwards, then my gluteal fold will tilt towards the opposite side. That could go together with some pelvis rotation. We don't know yet, we will quantify in a minute. So, subjectively impressive, the arm swing. Look at how the arms are swinging back and forth. So that tells us about a high moment, a high impulse that the trunk is actually moved into. Now before we mess around with other parameters, let's take a look at the 4D motion and just look up the pelvis data, which is that one. So, there we go. So I in the first sample I wondered why this is actually showing some kind of a small graph, but I added another parameter there. So, but for the pelvic drop, we can see it's more dropping to the right side here. So that is coming to 8 degrees on the right and 3 degrees to the left. As for the pelvic rotation, very sinusoidally oriented, with a maximum of 10 degrees on the left and 11 degrees to the right. Now, if you have followed along, so at an earlier moment I talked about 5 degrees of pelvic rotation. So that should be the desirable value. And the 5 degrees of a pelvic rotation will always take place during the hip extension. So hip extended to that side, pelvis rotating to that side, opening up, creating the 20 degrees and creating step length. So this is just adding to the step length. 5 degrees. And my entire motion pattern is oriented towards 5 degrees to each side from that starting point. So a 10-degree range of motion that we can speak from. Now, you will hardly find a patient that is perfectly able to move 5 to 5. So that's not barely visible. So most patients have some kind of a slight asymmetry. But all of the asymmetries come within a range of 10 degrees. So then we don't speak from 5 to 5, but maybe it's 8 to 2, which is just a result of the timely context where I would need 8 degrees on one side in order to increase the range and the reach distance of my swinging foot on one side, And though don't have any time to move into my sufficient 5 degrees on the other side, because then the swing phase is already over and I will get stuck at 2 degrees. So I will walk around 10 degrees of a range of motion, no matter what. So if you have patients that come with a reduced range of motion, so maybe only 2 or 4 degrees overall, so then you know about a high impairment in pelvic rotation that could come with higher degree hip arthritis patients, for example, so that where some pain is really preventing them to moving to a proper rotation. That could be, in her case, an exaggerated pelvic rotation, which, if my timely sequence is dedicated to 5 degrees to each side, now we're talking about 10 degrees to each side, is a very impulse-driven movement that we need to expect from her, and that would be something that could be correlated to the arm swing. So I have an impulse, and that will really drive me to that desired 10 degrees that I need for my motion pattern, for my end result in the functional profile. So 20 degrees of range of motion in the pelvis will never be achieved without a proper impulse that I set. This impulse comes at a cost, and I will talk about the cost at a later stage, but now let's have a good look at the leg axis. Now if we're looking at her lateral leg axis and just focus on the hip angle, so then you see there's barely any hip extension that we can observe. So the angle gets stuck at maybe 5 degrees, not even. What is it? 5 degrees of an extension at max, where it is supposed to be 20. And she already moves into 10 degrees of pelvic rotation to make a visible 5-degree extension in the hip. Now here you can also get an impression of the pelvis rotating quite much, don't we? Now, as secondary, we can also observe where she creates even more step lengths to get to a proper functional result. So this is what is happening in the knee. So you can see that the regular knee will be that first peak and then the second peak. So now she has some kind of a first plateau from which she moves into the into one entire peak, which goes a bit more too much into flexion. Now this is where we need to stop the video at a certain point and see whether we can find this. Now she touches the ground, now moving, allowing for some knee flexion, but instead of now moving back into extension, she keeps that flexion angle. Why does she? Moving on, you will see as the leg is moving into extension, thereby she is able to keep a forward tilted tibia that can increase the reach of the swinging foot, just because it's not standing like this, but like that, and that will enable me to move that other foot maybe some centimeters more forward. So, in that case, where we normally would expect to have, well, a perfect knee extension, she's still in a flexed knee, and that will tilt the entire body system so much forward so then she is able to create a proper step length. That will be some kind of a functional profile. As I said, this is a hip arthritis patient. I once presented this case in a training, had a group of doctors sitting in front of me, and somehow the mood was not very good. And I presented that case, and they said, how on earth can I say that this is a hip arthritis just by the measurement data? Well, you are not able to do that. So just the measurement data will not give you an information that this very patient suffers from a hip arthritis. You will need an X-ray. So there is an X-ray in this case. So we have everything there. So let's see. There it is. So you can see the bony lines here and there. So it's all there. So the hip arthritis is there. Why should I go for a gait analysis in her case? Again, I'm talking about the context. We have a 46-year-old patient that comes with a severe hip arthritis with a good potential in compensation, in functional compensation, with maybe a good demand in quality of life, and maybe also with the potential to reach this just with a bit of an exercising, which she might be able to follow along given her age. So if we now look again at this data, maybe look at the foot pressure here. Now we talk about the functional outcome again. This is where I go to the parameter sheet here. So again, rather small, but I will translate everything that is necessary, but still, how on earth can we describe, what do we need that analysis for if we talk about hip arthritis, which we already discovered in an X-ray? We need it to explain the functional profile of the patient, which an X-ray can never give you. We want to explain to the patient, look, this is the status, this is what we can achieve if you stick with the therapy, or maybe also managing a bit around, well, this is something I would not recommend to do or define as a therapy goal, because this might be too much. So either way, we can use this to somehow, well, explain to the patient and also decide on which potential we could make use in a therapy approach. So it's the context. And if I'm looking at all of her compensation, and she has a severe impairment in hip extension, she has a lot of pelvis rotation going on, which is a waste of energy. So that's really costing a lot of energy exertion. And she is also provoking some knee flexion where she's not supposed to have it, and all of that, the arm swing, all energy wasting. But in the very end, if I look at the result parameters in the parameter sheet here, so we have a step length. This is 56 centimeters on the left and 57 on the right. We have a cadence of 120 steps per minute. Great. We have nearly equally distributed and regularly distributed phases. The contact phases of fore, mid, and rear foot, perfectly aligned and not too asymmetrically set. We have a good outer rotation in the foot. Everything looks like a very promising sample in terms of the outcome, of the functional outcome. So she's able to compensate quite well, but at a cost of high energy exertion, which maybe if she turns, now she's already over her 50s, now if we talk in 2026, if she approaches 60 years, she will never be able to go into that energy exertion again, and she will need to go another way in compensation. In that case, she's highly compensated already, so we could assume a loss of function in the future, in the near future actually, because this is really energy wasting. So this is something we can use as the status quo. This is how we see our patient now, and this can be the starting point for any intervention that we could think of. Now if we take a look at the 4D motion again, we know about the pelvis rotation. Now let's talk about the spinal movement here, because this is really something that could add just another tone to the entire diagnostics. So when we talk about walking, we talk a lot about rotation. And the rotation is basically what we can see here. So we talked about this in the coffee break. So this is again the same graph. So we have that red rotation graph. Whenever that graph turns to the left, muscle-spinous process turns to the left. Whenever it turns to the right, then muscle-spinous process turns to the right. And as you can see, we have a rather symmetrical overall distribution. So it's turning to the left, it's turning to the right. Never mind 2-3 degrees of an asymmetry. That's part of the pattern. Nothing that we need to consider. One thing that is obvious is that it is really wide at the lower end, because this is always the counter side of the pelvic rotation. So if my pelvic rotation goes 10 degrees to the right, so the surface point will go 10 degrees to the left here. So that's always reflecting the opposite of the pelvic rotation. The timely sequence is the secret in reading this. So the timely sequence of a rotation in the spine starts with the pelvis rotating into one side. And then we are not talking about a segment-wise rotation of the spine, but in a block-wise rotation. Means that the lumbar spine will follow along that rotation impulse. If my pelvis is rotating 10 degrees to the left, my spinous process will rotate thereafter into the same direction. So means sacrum to the left, pelvis to the right, then followed by the lumbar spinous process to the left, then the lower thoracic spine up to T8, then the upper thoracic spine up to C7. These would be the blocks I would speak from, and those should just move into the rotation one after the other, and once we reach the rotation movement in the upper thoracic spine, the pelvis is already counter-rotating and initializing the counter-rotation movement. So you should expect some kind of a spiral movement that moves upwards, with the pelvis initiating, lumbar spine following, and then thoracic spine following along. Actually, there is one graph that could give you that kind of an information, which is hidden in the vertebra tab, more like the quantifiable way of looking at this. But if we look at this, that would be the subjective and the most obvious one. If you just try to subjectively look at the graph, how it's transferring from bottom to top, that sequence of rotating, so you can see there is a bit of a spiral already going on. If just looking at the pelvis and how, well, everything that comes on top of it just comes a bit in a delay. So that's all fine, but it all gets stuck right here. So there, the entire system is not following the sequence by any means. So we have a complete counter movement, especially when rotating to that side. We have a clear angle in this graph, and that's basically where she decelerates a lot. So that means she has initiated a lot of pelvis rotation, her arms swing a lot going together with it, and in order to prevent the head from rotating with it, that's basically where she needs to decelerate at a certain point, and her individual point is located directly here. So this region is prone for showing some muscular blocks, some muscular asymmetries, some rigidity in order to withstand these high impulses that get created there. There's one little difference I want to make you aware of if we talk about the rotation, which refer again back to the static examination where we had the pelvis correction as the 0 point in the surface rotation. As you can see here, this is the actual movement of the pelvis integrated. So this is how my patient is moving on the treadmill. So like in the free environment. Sometimes this has nothing to do with what we show here as a rotation with the vertebrae with the pelvis below, because if there's a lot of equal rotation, so then we don't see any rotation of a vertebra at all. In her case, for example, we can see a large extent at L2 here. So this is obviously the lumbar segment that is rotating the most in the lumbar spine. And we can see that at L2 there is a quite large extent of rotation. But there's not much rotation against the pelvis. Therefore, L2 has a very low extent of rotation overall, because it will just being smashed into that rotation position by the pelvis itself and will not counter-rotate that much. This work she takes over in T4. So because this is the breaking point here, so that large extent of rotation is the counter-rotation against the pelvis that we can visualize in this column here. And you can see T4 as that blocked area here is actually moving as the highest counterpart against that high degree of a pelvis rotation. Please.
The thoracic rotation is occurring because of the pelvic rotation? Or arm swing?
So arm swing on one hand, so is definitely influencing this.
Because when you look, the thoracic rotation is just in the same direction with the arm. The pelvis is rotating against, because therefore the thoracic part is beginning first, then the pelvic part and the counterpart of the lumbar part is
rotating. Exactly. And this is actually the counter movement.
Yes, this is we see the same situation, especially when there is a sacroiliac joint fusion. For example, in
same thing.
There is a sacroiliac joint fusion, and the sacroiliacs also, very prominent osteophytes. Probably therefore, she's trying to move everything through the trunk.
Somehow.
The thoracic part is starting
the
rotation.
Exactly.
Therefore, you find the thoracic part is first.
Exactly. Right on, spot on. So that's put together quite well. So of course we have a thoracic rotation, but it's used primarily to decelerate. That could also include the arm swing then, to somehow deal with that high degree of an impulse, which in the lumbar spine obviously will not be covered, not be compensated. So we need the thoracic spine to do that in order to keep the head somehow aligned to the direction of travel.
For this person, if she doesn't have any complaint, do you see any therapeutic advice for this situation? Preventive things or?
Actually, I would. And basically, what we need to see is how much the bony restrictions will be part of the planning of what I could somehow add as a therapy. But as for preventive action, I would surely try to get her somehow aware of the fact that she's already in a status of compensation that is really highly advanced, and so will not be able to be fulfilled in the long run. So in order to prevent her to run into severe problems in her 60s, we should now need to take her functional capabilities that she has at her age and at her compensation method to somehow improve the muscular situation in a way that it can cover a bit of the bony and joint restriction, and to save that energy that she needs to exert in this sample here, to simply reduce the entire load to the entire body. And of course, well, I think could only turn out positive also for this, but that would surely not be the main point actually, because this is only, well, that counterpoint which, if my impulse gets lower, will then also get a lower load to cover.
Does it mean that we want to keep the flexibility during the coming years for all the places where she needs all this compensatory movements?
That could be one approach. Keep it. or even try to improve. And maybe also find out whether we are really able to improve the situation to a sufficient situation. She should be able to compensate slightly, but she should also be able to work around this in a muscular way, in a way that she's exerting less energy in each step. If she's not able to do so, that could be a bit controversial, but when working in a therapy, I had very good experience with patients who decided to a hip replacement in the early years, because the function, the tissue that you can work with in rehabilitation is way more, well, let's say, open for stimulation and for recruitment than it is when the patient, compared to if the patient would wait 20 more years and we have a more worn down system with less mobility, with less capability and less view to a positive therapy outcome. And you see this especially actually in knee arthroplasty, so where we know that knee replacement is a totally different story comparison to a hip replacement, also from the function that we can work with thereafter. And then given an elderly patient that worked around the arthritis that was basis for the replacement for several decades, will not be able to get a proper rehabilitation result in a good time span. So he really needs to work on that, and given, well, the capability of an elderly patient with a high compensation in his history, also there, a joint replacement where recommendable in the early years is no knockout criteria. So you can actually use this as a thought process, which does not mean that each patient that has a high deviation needs to undergo surgery at that in that stage, but we can keep this in mind in certain cases.
If she's aware of this compensation, and could it be an idea to take smaller steps to have this to avoid the overuse of your compensatory mechanisms?
It could be a trial, absolutely. So maybe try to make her aware of taking shorter steps, whereas she's in a normal step length. So everything that you would shorten would actually also shorten her reach distance. So that means the shorter her steps get, the more steps she needs to take to achieve a certain distance. So then we need to see whether this could work out for the patient. Is totally open, totally fine, and if she's accepting this or also responding well to the therapy approach, that's all fine. So then you can think about this. Not sure about how we could be able to integrate some more hip extension. That way we would need to understand a bit more about the bony restrictions in the joint. But basically, we could be open for everything. So she's young, and we can actually try on her quite well if we just make her understand the situation, and that's what the measurement is actually for. We don't want to analyze the hip arthritis there from scratch, so that's what the X-ray is for, and that's perfectly the best system to use to describe an arthritis. But as for the functional outcome, a hip arthritis is not equal to a hip arthritis. That's part of age on one hand, but also, of course, of the compensation and of the history of muscular imbalance. On the other hand, maybe some things that happened, some injuries that happened in the past will also contribute to that. So we all take our own package and then build up from that. And that's, well, basically what will end up in a functional result like that or like another if you have just similar symptoms or a similar diagnosis but other symptoms that way around, or another functional compensation method. I would say that not every one of us would be able to integrate 20 degrees of pelvis rotation into his motion pattern without reaching a very severe level of lumbar pain. Okay, let's see. Let's go for an easy one. I wanted to show you the butterfly also. So let's see. So where's my mouse now? So now the reflection is really a pain. Is it somewhere? I'm not sure. So there we go, on and off again. It's a crappy product, actually. Where do we have it? There we have it. Okay. So what is it? There we go. So this is a patient. You can see it from the black textile that's covering the right lower limb. Suffers from a fiber tear in the gastroc. So that's how we did the measurements. So no marker tracking here, so we're just documentation. Also, that's sometimes fine. We just let the video run to get a subjective impression. Nothing as data to be saved. Maybe, I don't know whether, well, a knee angle would be something of interest here, or maybe a rear foot eversion. So then you can just go for plain documentary and have the video at least included. Now, what you can see is actually a good, well, let's say it is some kind of a Duchenne sign. You can see how the upper body is moving left and right, and wherever the right foot is loaded, the trunk also sways to that side again. So this is a data or a sample that we can plainly correlate with the foot pressure. And well, let's move a bit front. We can see we get rid of that half of a foot. There we go. So as you can already see from the width of the ground reaction force curves, you can see that the left side is way wider than the right side, so the contact duration of the right foot is already limited. And as for the force, you can also see that the red graph overall is higher than the right graph. So that right side, of course, as impaired, painful, fresh muscle fiber tear will always be a bit lower than. And we will simply go to the gait lines. Oh, that's where we'll need the magnifier again. And then we end up with this center of pressure butterfly. So as for the butterfly, it's called the center of pressure butterfly as it is supposed to be a butterfly shape. So that means I have one left triangle and one right triangle, and normally they should expand like a wing of a butterfly. So we have a vertical line which is unilateral contact, so that's only one foot on the ground. In the moment where both feet are on the ground, we are moving into that crossing section here. So that would identify how long my foot is actually placed into monopedal position. You can see that as for the rear end of the vertical, roughly at the equal level, but as we move to the front, that would be towards terminal stance of the right foot, then we suddenly already break here and then transfer the weight. So that's more or less like this. So that's exactly the pattern that we saw, but the center of pressure butterfly does reflect this rather well. And now let the healing process then walk on. Then we can maybe add some small therapy to it. And we have an after measurement, which just came in, I think, 2 or 3 months later. And our center of pressure butterfly looks like this. So perfectly restored. That could be self-healing, of course, if it's a muscle fiber tear. Maybe we can add a bit of a therapy, but basically this is something you can perfectly compare, and it's just that part of the butterfly wing that we added to the function. So this all gets added to, well, the rollover behavior and to the stability of that rolling over and the push-off quality, of course.